Limitations and Management of Dynamic Navigation System for Locating Calcified Canals Failure by Yang et al. In 2024 in the Journal of Endodontics. Pulp canal obliteration, calcification, or calcific metamorphosis is the progressive narrowing or complete blockage of the pulp canal space. This process involves secondary dentin or tube-like calcified structure deposits within the canal walls. It is associated with dental trauma, vital pulp therapy, revascularization, caries and restoration, physiological changes in elderly patients, genetic factor, and systemic factors. The use of advanced equipment like the CBCT scanners, dental operating microscope, the ultrasonic instrument for removal of these obstructions, and emerging technology guided endodontics like the lab fabricated templates and dynamic navigation system had increased the accuracy in planning and treatment of calcified canals. The DNS combines three-dimensional CBCT imaging reconstruction and spatial location registration technology using an optical tracking system controlled by a dedicated computerized interface to provide a real-time navigation guiding the operator to drill following the preoperative planning. These case reports aim to describe limitations and management of the DNS improvement and failure in severely calcified canals. An informed consent toward taking, and the clinical procedure of the dynamic navigation technique includes the preoperative CBCT scanning, preoperative drill path designing, which the CBCT data were uploaded to the endodontic navigation software according to the laws of centrality, concentricity, and cemento-enamel junction. The drill path was designed to pass through the CEJ center in the coronal, sagittal, and horizontal views of the CBCT imaging. Calibration and registration, the principle was based on the optical tracking system that emits the infrared light, and the handpiece and the reference devices were calibrated together. Real-time dynamic navigation, the pulp chamber opening and canal location were performed under the DNS. Before the tooth drilling, the short round burr was placed in the mesial, distal, and central positions of the targeted tooth at different angles to confirm the correct tooth position, calibration, and registration. Rubber dam was placed, and the DNS constantly tracked the handpiece wings and the reference devices, providing visual feedback to the operator. The dynamic movement of the actual drill path was presented as images on the screen, including the location, angle, and the depth within the CBCT imaging and pre-designed drill path. The location and angle windows displaying green revealed that the actual drill path was clinically within acceptable range, and the depth window displayed green indicates that the burr was within the pre-designed depth. So for the first case, she's a 27-year-old woman, came on March 2022 complaining about a pustule on her maxillary right anterior tooth for 2 months. She underwent orthodontic treatment 14 months ago and a previous history of trauma 10 years ago. Clinical examination revealed that both teeth number 7 and 8 presenting with physiological mobility and no percussion tenderness. However, both did not respond to thermal testing and electrical pulp test as well. And a sinus tract was present on the tooth number 8 mucosa. A periapical radiograph revealed that both teeth has a calcified pulp chamber and canals, discontinuity for the lamina dura of tooth number 7, and apical radiolucency over tooth number 8. So tooth number 7 was diagnosed with pulp necrosis and PCO, and tooth number 8 was diagnosed with pulp necrosis, chronic apical abscess, and also PCO. Root canal treatment was performed over both teeth. The sinus tract on the buccal side has healed as shown in figure L, and 1 year later the patient underwent CBCT scanning for orthognathic surgery, which confirms the healing of both teeth with apical radiolucency disappears. For the second case, he's a 59-year-old man referred from the Department of Periodontology over June 2022. The result in a periapical radiolucency of tooth number 9. The patient complained of abnormal left upper front teeth mobility for several months. Clinical examination revealed a deep overbite and a premature contact over tooth number 9, and also a discoloration with a grade 1 mobility. And tooth number 9 experienced pain to vertical percussion with no response to thermal testing and also electrical pulp test. A periodontal pocket ranges from 5 to 7 millimeters, and a gingival bleeding was presented as well with a discharge of pus. Periapical radiolucency was revealed over a radiograph, and CBCT images showed that the alveolar bone loss and apical bone defect were not through and through. Tooth number 9 was diagnosed with symptomatic apical periodontitis, PCO, and chronic periodontitis. The therapeutic schedule was a root canal treatment combined with a periodontal treatment. The drilling equipment was adapted with a round burr, and the canal was located without excessive loss of the tooth structure, and root canal treatment was performed. After 1 year, the periapical radiolucency revealed that apical radiolucency and ciliar extrusion was also decreased in size, and the periodontal condition of the patient was improved.